Kia ora, ladies and gentlemen. A very warm welcome on this lovely Wellington day. My name is Philip Kearney and I am the Chief Executive for Arthritis New Zealand. And it is a truly great day to have Professor David Hunter here today to address you. I think you'll find extremely enlightening what he has to say today, and certainly from the feedback we've had from Christchurch, truly a good session. And I suppose the thing that I would like to do today is also acknowledge a couple of our trustees here, Martin and Roy. Thank you for coming along. These are people that give immense amount of support and expertise to Arthritis New Zealand. Very much long-standing and serving board members, and we really appreciate the input you have. And also I'd like to acknowledge some of my colleagues here too, who work very intently on supporting those with arthritis, and it's really appreciated that they could make it as well. Right, and the last thanks I'd like to make is to Aidan and Abby. Aidan, thank you again for the support Abby give us in being able to put these sort of speaker series on. We couldn't do it without you, so thank you so much, and it really is appreciated going forward. Thank you. Right, just before I introduce David to you, I just wanted to put a bit of a lens on arthritis here in New Zealand. 670,000 people have arthritis. That's about 1 in 6. And of course you'd think that you have to be really old and with a Zimmer frame to have it, but 1 out of every 2 is still of working age. The interesting thing is that by the year 2040, 1 million people will have arthritis. That's a massive increase. And why today is important is that we think we have to start changing the way we manage arthritis, because we will not have the facilities, we will not have the personnel to continue on the same path that we have today. We need to start thinking about alternatives. And to put it into context, this report that we did recently, you may have seen it on our website, and it's a great reading, I can tell you. Obviously a bestseller coming up. It's the economic cost of arthritis in New Zealand. 12.2 billion a year. That's what it costs. And it's broken up into 3 areas. The first is obviously the direct cost, which is hospitalization and so forth, which is $1 billion. And then the second is the additional costs, those hidden costs, which are the likes of absenteeism, the things that actually cost us but don't directly cost us in terms of monetary cost of our system. Well, I suppose it does in terms of work. And then there's the third cost, that's about $3.3 billion. And then there is about $7 billion, which is what we call well-being. And that is actively used now by Treasury to measure the impact on those conditions that are in New Zealand. This is a big cost. Goes to $1 million, then it's going to be more likely $20 billion. We need to start thinking about actually actively managing arthritis. We need to make it certainly more prominent in some of the policymakers and some of the leaders in the DHBs. And I'll make one comment very quickly. I was part of a conversation with a DHB, which will remain nameless. And they said, we've got a problem with musculoskeletal demand. I think they're non-compliant 10 out of 12 months in terms of reaching their targets. And they didn't have an answer other than to build more theatres and to get more staff. And so when we talked a little bit about what the alternatives were, like actually better management, they said, we don't have any money for that. Hopefully David's comments today might show that literally we need to have that more seriously, taken more seriously. Anyway, I'll stop because David, you've come to speak here rather than me. I'm going to do a quick intro, and David has asked me to. It's a great intro because it really does show the impact that David is having on this area. So Professor David Hunter is a rheumatology clinician-researcher whose main focus is clinical and translational research in osteoarthritis. He is the Florence and Cope Chair of Rheumatology and Professor of Medicine at the University of Sydney, Chair of the Institute of Bone and Joint Research, and Staff Specialist at the Royal North Shore Hospital and North Sydney Orthopaedic and Sport Medicine Centre. Now that's his day job. He is ranked as one of the leading experts in the world of osteoarthritis on his Expertscape, and is the section editor of Up to Date Osteoarthritis. He holds a medical degree and a Masters of Sports Medicine from the University of New South Wales. He completed a Fellowship of Rheumatology at the Royal Australian College of Physicians and earned a Masters in Medical Science, and that's Epidemiology, from the University of Newcastle, and received his PhD in 2001. His research is focused on a number of key elements in OA, including the epidemiology of osteoarthritis, the application of imaging to better understand structure and function with application, to both epidemiology research and clinical trials. And the part I like about it is also looking at novel therapies in disease management. And he looks at the health management service as well. He is an editor for the leading international journals in his field, has authored books on osteoarthritis, and has had over 450 publications, peer-reviewed journals. I'd like to welcome David.
Thank you very much, Philip. It's a great pleasure to be here. The only request I made of Philip was to keep it short, and he didn't follow that request. But anyway, thank you very much to both Philip, Arthritis New Zealand, and particularly to Diane for looking after me while I've been traipsing around the country and over the next week. I'd like to acknowledge the trustees who are here, and obviously everybody else who's come along to listen to me today. I've got a couple of presentations today and one tomorrow morning, and today is, I think, the most important one, at least from my perspective, and that's speaking hopefully to people who have arthritis and who here presumably because of personal interest. And I'm going to break this up a little bit, and so largely talk to you about, I guess, the ways I would see management happening, the way I would like to see management happen for people that have arthritis in the community, and specifically for people that have osteoarthritis, and then leave it open to your questions, because I think you'll learn a lot more from your colleagues than you will from me. So by all means, listen to the first half of the presentation, but I think save up your questions, because very happy to attend to those in the latter half of the presentation. In the first instance, I do want to acknowledge my primary means of support that comes from the National Health and Medical Research Council in Australia and Arthritis Australia. And I do some consulting work for some companies on agents which we call disease-modifying agents. So they're not currently available in Australia or New Zealand, and it's probably about a decade away before they will be. For those of you that have a particular problem with sleeping, and you want some help to get you to sleep, these are some references that might be of interest to you. All right. The top portion of the slide is really the more scientific pieces. So if you really want the scientific pieces, that's where I would encourage you to concentrate. If you want things that are more in layman's terms, this is a website we put together with Arthritis Australia called myjointpain.org.au. And it just is a wonderful resource. I'll talk again a little bit about that later on. But a wonderful resource for the general community. And if anybody wants to follow me on Twitter, I do send tweets out occasionally just to keep Haxby amused. All right, so I'm going to start off with, and I think it's really helpful, Philip set a very helpful context, and specifically the New Zealand context about arthritis. So this is an incredibly prevalent problem, very disabling to the people that are affected, and obviously has a massive socioeconomic impact on our communities. That's where I'm going to start. And then we're going to talk about the traditional ways that we manage osteoarthritis at the moment and tell you why we should be changing that, and then concentrate in the latter portion of the presentation on what we ideally should be doing for the management of osteoarthritis. I'm going to start off with, though, talking about what this disease is. So for those of you who are here to hear about other diseases than osteoarthritis this afternoon, you may be in the wrong room. But osteoarthritis is a disease that can affect any of the tissues within the synovial joint. Historically, it was just thought of as a problem of cartilage. And it's important you don't understand it that way, because cartilage does not contain nerve fibers that are responsible for the pain that you present with. Other tissues are much more important from that perspective, specifically the bone, the synovium, the lining of the joint, the capsule, the muscle in and around the joint are much more important for why a person presents with pain and limited function. And so the disease is that structural change, but the illness, which is what's important to you, is that being associated with pain and limited function. So the structure in and of itself does not matter. And I'm going to come back to you why that's important later on, because of the penchant these days to image everything that moves. And I'm suggesting to you that that's not the best way that we should be going about diagnosing this problem. I'm going to start off with a little bit of prehistory, though, for the history buffs. And many of you hopefully are familiar with a movie called Nemo, or Finding Nemo. And this character's name is Bruce, and he's a great white shark, and he's lucky, okay, because he has a cartilaginous skeleton. And by virtue of the fact that he has a cartilaginous skeleton, he's not at risk of developing osteoarthritis. So to develop osteoarthritis, you have to have both bone and cartilage. You can't do it with cartilage alone. Okay, so just understand that this isn't just a disease of cartilage. Creatures like Bruce are not susceptible to this. Other creatures like sloths, similarly, don't develop osteoarthritis, primarily because their joints, when they're hanging upside down in a tree, are distracted, so they're pulled apart from one another, as opposed to compressed. So for mammals, including humans that develop osteoarthritis, for us to do so, we have to have bone and cartilage, but you also have to have compressive forces upon our joints. Don't walk away from that message with the understanding that activity is bad for you. That's the wrong message, okay? But those are two things that we need in order to develop osteoarthritis. How many men in the room love to hold the remote control at home? This happens in your house as well? Okay. So a few of you, all right? So theoretically, we evolved from apes. And I used to live in the US, and I used to go down to the southern part of the US, and they used to get quite offended by this statement. But there are a lot of people, including Darwin, who believed that we evolved from apes. And one of the things that we did as far as our evolution was concerned is we developed what's called an opposable thumb. So our thumb is able to cross across our palm. So we can grip things like the remote control. But that opposable thumb increased the mobility at the base of our thumb. So placed us susceptible to the development of osteoarthritis in the base of the thumb, which apes don't get. Okay, so humans, by virtue of the fact that we can hold the remote control and operate it to our heart's desire, means that we are also susceptible to the development of osteoarthritis in the base of the thumb. So again, something to bear in mind. Our evolution is continuing and it continues to this day. So again, just to, I guess, paint the picture as to why this is a massive problem. So this is a study that came out relatively recently, 2017, and compared the prevalence of disease in skeletons in the early industrial to the post-industrial period, so modern day and age. And this is all adjusted for things like age, body mass index, obesity, which are two of the main things we think is currently driving osteoarthritis prevalence. And you'll see from that slide that essentially the number of people who are developing osteoarthritis has doubled in the last 100 years. And it's not explained by age, and it's not explained by body weight. At this point, it is unexplained, but I think there are large other societal changes that are going on that likely also play an important role in why we might be developing osteoarthritis, including things like the built environment. So the surfaces upon which we walk, the shoes that we wear, the muscle bulk that we have also likely play an important role in why we see much more osteoarthritis these days than they did even 100 years ago. Okay, so why should you care? Well, I look out at the room and I would imagine for some of you, you're here out of personal interest. You're maturing, and as part of that maturation, you've developed pain in your joints. It happens to a lot of us. As Philip said, a large very prevalent problem within the New Zealand population. Over 400,000 New Zealanders have this problem. And it's, again, more common amongst people who get older. One of my helpful colleagues at work sent me this picture the other day of me supposedly gracefully aging using an app that they have these days. So it's happening to all of us. The other reason why I care is because of very personal interest. So these are my two grandmothers. This is my Kiwi grandmother, Laura, who, so my father's family originates from Invercargill. And so this is Laura, and on her right-hand side is my Australian grandmother. We affectionately knew as Chief, and she was an irreverent person, really had a lot of distrust for authority, and we played a lot of card games as I was growing up and basically spent a lot of time with her. She was probably my closest relative at the time while I was a young kid growing up. My first 5 years were in New Zealand, which were magical, but most of my childhood was in Australia, and so I spent a lot of time with her. Shortly after graduating from medical school, I was overseas at the time, I found out that she'd gone into hospital to have a joint replaced, specifically her left knee. And within a week of that, unfortunately, she'd succumbed to perioperative complications from infection. For a procedure, honestly, she probably didn't really need to have, but was the only thing that was offered to her at the time. And so there's a lot of things that we can improve upon, and hopefully I'm going to elaborate upon that later on. Don't concentrate too much on the right-hand side, but essentially this is an MRI of my knee showing that I have full thickness cartilage loss in large portions of my right knee. And if you see me hobbling today, that's by virtue of things that I did to myself yesterday on a bike in Waiheke Island. But, and it probably is partly attributed to that, but walk away with the message that I have this disease, I care about it for lots of different reasons, but don't necessarily get an MRI. We did this as part of a research study. So when I come back to the imaging piece, understand the contradictory message that I may just have given. But just to start off, this is obviously an incredibly common problem. 1 in 8 adults in the Western world, 400,000 of your fellow compatriots in New Zealand, 250 million people worldwide have this problem we know of osteoarthritis. And for the people who are affected, it provides a massive burden, and it largely presents with a person with pain and limited function. And that pain originates in a very complex way. So you're probably very familiar with people getting x-rays and sometimes MRIs of their joints to better understand the structural changes that might be going on within the joint. And recent MRI studies have suggested that bone marrow lesions, inflammation of the lining of the joint we call synovitis, and swelling within the joint we call effusion is responsible for a large portion of variability within a person and between people as to their pain severity. Okay? I'm not suggesting to you that's the best way of identifying whether you've got disease or understanding where your pain's coming from. More often than not, it's a waste of money getting an image like an MRI because it's not going to tell you anything that's going to affect the management that you have. It's much more important that you understand that other factors play a really important role in why a person's pain may be variable over time. And here I'm thinking particularly about things like depression, stress, anxiety, catastrophizing, that play an incredibly important role in the variability of a person's pain experience and how that might change over time. And I'll belabor this during the course of today, but it's really important if you have a mental health problem like that, over and above your arthritis, that you pay attention to that and deal with that. Because a lot of the things I'm going to be encouraging many of you to do, which is around exercise, losing weight, being more proactive in your management, is a lot harder if you're depressed, and that's driving you towards eating. Okay? So pay attention to those symptoms because they do play a really important role in your pain experience. Just some important statistics for those of you who like statistics. And you've already got that grim look on your face as though you're bored of my statistics already. Is that right? But for every 2 in 3 patients, the last time they were pain-free was over a year ago. Okay, so just reflect on that for a second. 2 in 3 people with arthritis, the last time they were pain-free was over a year ago. So it has a huge personal impact. And I know for many of you are probably sitting there immediately understanding that impact. As Philip said before, this isn't just a disease of older adults. 2/3 of the people that are affected are of working age. And the importance of that is that that has massive downstream socioeconomic consequences as a leading cause of premature retirement in our society. So a lot of people retire as a consequence of their inability to do work because of their osteoarthritis. And for those of you who are into the socioeconomic impact in the community, 0.5% of the GDP is spent on care related to this disease. And that doesn't sound like a lot, but I'm sure if you told your government that you could save them 0.5% of their GDP and stick that back in their coffers, they would take it in a heartbeat. Okay, so for the average person that develops osteoarthritis, the course of that disease usually runs on average about 30 years. By and large, it starts with early structural changes going on, with very subtle biochemical changes and subtle changes that we might see on high advanced imaging in bone, cartilage, and other tissues. By and large, we spend most of our time as clinicians focused on the last few years before what we call joint death, end-stage joint disease or joint replacement. So this whole time course takes about 30 years. Most clinicians focus on the last 3 to 4 years. And I'm going to be hopefully banging the message forward today that we should be very much focused on what's happening out here, because that's where we can make a big, meaningful difference to the course of this disease. So at the moment, what we do is we palliate people. And if you've heard of the word palliation or palliative care, it's meant to sound a little bit pejorative in this context, primarily because about 80% of people that have osteoarthritis, their management consists of going along usually to a primary care doctor, being prescribed an anti-inflammatory or some other form of analgesic, and when that doesn't work any longer, being sent off to see a surgeon, usually for a joint replacement or another elective surgical procedure. So that's about 80% of people that have osteoarthritis follow that pattern. And most of my message today is to try to convince you that there are much better ways that we can manage this disease than that. Starting with prevention, and I'll talk about that in a moment, but then particularly about progression and what you can do about existent disease and the management of your symptoms. I'm going to start off with prevention. And I'm going to apologize in the first instance. A lot of what I've got to say today is very much knee-centric, and I will have some hip and hand-centric messages later on. But about 85% of the disability burden related to osteoarthritis relates to knee osteoarthritis. So that's why I've tended to focus a little bit more on knees than other joints. If we look at the reasons why people develop osteoarthritis of the knee, about 75% of that is modifiable. So about 45% is attributable to overweight or obesity, and about 20% attributable to joint injury. And both of those risk factors are modifiable. And as a public health agenda in our community, we do very little about either of them at the moment. Starting off with joint injury, I know New Zealanders love their netball and their rugby. And so within both of those sporting codes, tearing of the cruciate ligament, so it's an important structural component of the knee, is an incredibly common consequence amongst active sporting people. And it's not to discourage sport at all, but it's really to learn how to play sport safely. And so that's the message I want you to walk away with today. So every year, about 20,000 Australians, including people like Quaid, tear their cruciate ligament. And usually it happens in a non-contact incident. So you can see he's rupturing his ACL right there. No one's touching him. It's largely by virtue of the fact that he's landed on his knee with his knee buckling underneath him, which places his cruciate in a position of tension, stress, and susceptibility to rupture. So about 70% of people who tear their cruciate ligament will develop osteoarthritis within the next 10 to 15 years, irrespective of how it's managed. Okay? So in an ideal world, we would prevent most of these from happening. So reconstructing the ligament does not alter the long-term risk of a person developing osteoarthritis. So the mean age of people who are having these injuries is about 22. So most of these people who are developing osteoarthritis of the knee are doing it in their mid-30s, early 40s. And so you can see they're living for many, many years with disability as a consequence of that injury. We can prevent about 70% of these injuries by teaching a person how to land on their knee properly through programs like the FIFA 11 Safe Sport for Kids program in Australia, the PEP program, which is very popular in America. And in many countries around the world, particularly Scandinavian countries, they've rolled this out at a grassroots level, and it's reducing injury rates by about 60 to 70%. But unfortunately, In forward-thinking countries like yours and mine, they're not doing that. And so it's a huge missed opportunity. Again, about 20% of people that develop osteoarthritis of the knee do so because of this injury, and it's imminently preventable. The other massive risk factor here is obviously overweight and obesity, and there are huge societal pressures, both in terms of what we're sticking in our mouth, but also in terms of what we're doing to ourselves between times. So I'm not helping your problem right now because you've been encouraged to sit for the next 2 hours listening to me. Okay, so it's by virtue of caloric intake and reductions in physical activity that the number of people who are overweight or obese is growing exponentially. And so at the moment, at least in Australia, about 2/3 of our community are overweight or obese. And that appears to be increasing year on year. So there's a lot we can do about it, but unfortunately at the moment our government appears pretty rudderless to do anything about it. And these are the things that we've been advocating that they should be doing for a while. Okay, so there's a couple of blue lines which I think are helpful references on this slide. So anything below that blue line is not what we would call cost effective. So the cost per disability adjusted life year saved means that it is not something that we would consider cost effective. So the things where we're giving a person individual responsibility, things like Weight Watchers, from a public health perspective, is not the best way for us to manage overweight and obesity in our community. I'm not saying we shouldn't give people individual responsibility, we should, but it's just not a cost-effective way for us to deal with this from a public health perspective. The things that are above that blue line are cost saving. So from a governmental perspective, they're not going to have to spend anything that they're not going to redeem back in terms of cost saved. So this is things like nutrition labeling, banning junk food advertising, putting tax on unhealthy food and increasing physical activity. So things that probably make a lot of common sense to you, but unfortunately to governments that are under the power of sugar lobby and other powerful advocacy groups, they don't want to do anything about it. So again, things that will save us and our community a lot of money and also downstream have a lot of impact as far as preventing disease is concerned. Again, a huge missed opportunity. All right, so for the next little while, I'm going to talk about the way osteoarthritis traditionally has been managed, and ideally the way, I guess I'd like you to try to reframe the way your management has occurred. So as I'm going through this, just try to reflect upon how you've been managed, potentially as a person who has osteoarthritis or who cares for someone that has osteoarthritis. And I'm going to tell you a little story in the first instance. So this is Barbara. Barbara's a 65-year-old grandmother whose body mass index put her in the overweight category. She's got 4 grandkids. She used to enjoy bushwalking and playing tennis, and she had to retire from stacking shelves in a supermarket about 5 years ago because of pain in her knee. She went along and saw her primary care doctor, and the primary care doctor prescribed for her some anti-inflammatories, irrespective of the fact that there was a background of high blood pressure and a previous history of reflux. And that made both of those problems a little bit worse. She came back after that period of time with the anti-inflammatories not really helping her pain much, but obviously complicating other things a little bit, and was given a steroid injection into her knee, which lasted for a couple of weeks, but again, didn't really help her in a durable way or fashion. And so was then referred off to see a surgeon who recommended she have an arthroscopy of her knee. And so that story probably doesn't sound at all in common with your own, but is a very common scenario in the management of people with osteoarthritis, and I think helps to belabor the point of many people receiving what I would call inappropriate management. So this is a study that was published back in 2012 in the Medical Journal of Australia, and on that axis you can see the proportion of people who are receiving appropriate care for a range of common diseases. And at least for osteoarthritis, they estimated that about 40% of patients were receiving appropriate care. And I would suggest to you that that's a very generous estimate. I'd suggest to you that it's actually a lot less than that. So where are we failing people that have osteoarthritis? Well, in the first instance, most people who have osteoarthritis are complaining of pain and limited function. And more often than not, they're not being asked about their pain and limited function. So at least half the time, they're not being asked about their pain or how they're doing their activities. About 2/3 of the time, they're not being recommended appropriate non-drug treatment, like education, like weight loss, like exercise. It's about 2/3 of the time that's not happening. About 2/3 of the time, they're not being prescribed the right medication to help with their pain. But we're doing pretty well at referring to surgeons, okay? Not necessarily all patients want that. And so if I ask generally patients out there what their options are and what they're being afforded, most people say, well, I don't feel that I'm ready for a joint replacement. So there's a lot of opportunity for us to make a meaningful difference. But unfortunately, currently, the way our healthcare system is set up and structured is we incentivize the surgical intervention, but we don't adequately support the other opportunities to manage this disease appropriately. And so that's really what I'm going to try to emphasize today. And it starts very much with the communication about the disease. So when I use these terms, you're going to look at me blankly and say, well, no one has ever spoken to me about my osteoarthritis like that. But for many people who had their osteoarthritis described to them, it's been described to them as a wear and tear disease. And if they've had an x-ray put up on the wall, many people have said, well, you know, this is bone-on-bone structural change. And the unfortunate consequence of that is it's a misconception for the person who's describing it to you. So this is a disease where every joint has the capacity for repair, but unfortunately in the context of osteoarthritis, that reparative potential is being overwhelmed, usually largely by mechanical forces. People with bone-on-bone disease, it doesn't really much matter to me as a clinician what your x-ray looks like. We're still going to try to manage you in that way in the first instance, the same as anybody else who walks through the door. Does it increase your risk of pain? Subtly, but really subtly. Okay, so just because you've got bone-on-bone radiographic change doesn't mean that all of what I'm going to tell you today is any less relevant to you. But the unfortunate consequence of you being referred to as wear and tear and bone-on-bone is that you think your joint is vulnerable and that the only thing that will fix it is surgical intervention. And so that's the automatic language that gets used in many clinical practices. I would imagine for many of you, you've heard those terms before. And I'm just trying to suggest to you that there are lots of other ways that we can describe this disease that don't impact upon your treatment beliefs and hopefully get you more proactively engaged in the care. Now, historically, paracetamol or Panadol was the first-line analgesic that was advocated for the management of pain in the context of osteoarthritis. And so if we go back to guidelines, even 10 years ago, that was the first-line analgesic that was recommended. It is not these days. And that's primarily because for the average patient in the average trial, it does not relieve pain any better than a placebo. And it has a side effect profile not dissimilar to the anti-inflammatory group of medications. So it's not a benign medication in terms of its side effects. So that's a radical shift from guidelines, even from 10 years ago. Because New Zealand's perfect, the next comment is completely irrelevant to you, okay? But about 20% of Australians who have osteoarthritis are on long-term opiates for the management of their disease. So things like oxycodone, fentanyl, endone, those sorts of agents for the management of their osteoarthritis, about 20%. And it appears to be growing slowly. The best current evidence would suggest that provides the patient a risk of harm and no benefit. There is no evidence at all that chronic disease management for non-cancer related musculoskeletal pain benefits from the long-term use of opiates. So it's widespread in many Western communities, and I would assume it's widespread within New Zealand as well. But unfortunately, it carries with it no benefit and a real risk of harm. And the harms include things that we don't talk a lot about, but I think it's important that you reflect on. Okay, so this is a slightly old slide, but I just want to reinforce to you the fact that that red line is continuing to go up. Okay, so these are overdose deaths from opiates, cocaine, and heroin. So the opiates are all prescribed opiates, and this is in the US. We all worry a lot, appropriately, about cocaine and heroin and the deaths that occur from cocaine and heroin. But if we look at the number of people who are dying from prescription opiate overdose, it's vastly many more, okay? We also appropriately get worried about the number of people who are dying from gun-related homicides in the US. So if we look at the number of people who are dying from gun deaths per year, it's a little over 30,000. If we look at prescription drug overdoses from opiates, it's vastly more. Okay, we don't talk a lot about that as a society, but I know There's a lot of lay press publicity at the moment about a family called the Sackler family, who are from Purdue Pharma, who are the manufacturers of oxycodone. Johnson & Johnson were recently in a massive litigation suit that was actioned against them, primarily because of this problem. Opiate overdoses and inappropriate advocacy about the levels of addiction potential in these agents. So opiates have no role in the management of osteoarthritis. Similarly, many of you have probably never heard of this agent, but there's a group of agents called viscosupplements, hyaluronic acid injections, so things like Synvisc, Hyalgan. The best current evidence would suggest that an injection of salt water into your knee provides the same benefit as the injection of this product. And again, it carries with it a real risk of harm. And about 5 to 10% of people, they get a very painful swelling in their knee that occurs as a consequence of this injection. Corticosteroids, and this is where it gets a little bit more controversial if you haven't seen enough controversy already, but corticosteroids is probably something many of you have experienced at some point in time into your joint. Okay, it's a very widespread practice within many Western societies. In general, most studies would suggest it provides a mean of about 2 to 4 weeks of relief. It's a very short-lived benefit. So again, just reinforcing to you, this is a disease that has a duration of about 30 years. This injection provides you 2 to 4 weeks of relief. So I don't have a problem with a one-off injection, but unfortunately what often happens in this context is that people get set up on a repeated cycle every 3 to 4 months that they go back and have the same injection done. Little known data that's come out relatively recently suggests that that increases the rapidity of the underlying structural change. So this is a study, a randomized controlled trial that came out in 2017 that suggests that it increases your risk of cartilage death or progression. And a more recent, I didn't have the more recent study, but a more recent study that we did suggested the same thing. So it increases the rapidity of structural progression by about 3 times. Okay, so there's lots of different ways that I'll come to in a moment for managing this disease separate from that. Okay. This is Australia, and again, Australia is far more imperfect than what you currently experience in New Zealand, and a lot of people are nodding their heads in agreement. I'm just a little bit of cynicism there, but that's okay. So this is the state that I live in called New South Wales. So back in 2011, the state government came to us and said, look, we're embarrassed about the amount of time people spend on a waiting list for a knee or a hip replacement. Is there anything that you can do for them? So they're often spending 12, 18 months, oftentimes just waiting to see a surgeon, let alone to get on a waiting list for a procedure. And so we said, sure, we'll do something for them. So we targeted a program towards people who are on a wait list for a knee or a hip replacement. And this is the results of some of that program. So on intake, most of the people who are on the waiting list for a knee or a hip replacement, on average about 80% in these different public hospitals, had never had any appropriate osteoarthritis management before seeing the surgeon and being put on a waiting list. Okay, so there's lots of other things we can do for managing patients other than surgery, but unfortunately in today's day and age, including near where I live, most people, that's all that they're being offered. I don't know what your experience is like, but I guess what I've been hearing over the last few days is not dissimilar to that oftentimes the standard management practices is analgesia followed by joint replacement. And there's lots of other ways we can manage this disease that are a lot more effective as a community. Up until relatively recently, and when I say recently, about 3 years ago, the most common elective orthopedic procedure performed was an arthroscopy. How many people of you have had an arthroscopy of an osteoarthritic joint? Yeah, so quite a few. So every year, well, at least in 2015, at which point the NADA peaked, there were about 60,000 Australians having an arthroscopy for their knee every year for osteoarthritis. The best current evidence would suggest it provides no benefit over sham or physiotherapy. So just to give you a sense of what sham is in this context. Sham is you get wheeled into the anesthetic bay, you get put to sleep, someone makes a little nick in the front of your knee to make you believe that you've had an arthroscopy, then you get woken up. The people that have the sham do at least as well as those who have the real arthroscopy. Okay? So every person that goes through, it costs our healthcare system $5,000 a piece. So if we're doing 60,000 of them every year, that's a lot of moolah. A lot of money that could be spent on something else, but more importantly, carries with it about a 2% risk of clot in their leg, substantial risk of clot in their lung, and a small proportion of people die or develop infections as a consequence of that procedure. So it doesn't provide them any benefit, carries with them a real risk of harm and a substantial cost, but we still do a lot of that. So there's a lot of room for improvement there as well. Many people believe that the only way to manage this disease is to replace the joints. And I'll tell you that for many people, it's a good way to manage the disease, but for the vast majority of people, they don't need that. So the natural history of osteoarthritis is one where the vast majority of people, whether you're a man or a woman, whether you have knee or hip osteoarthritis, never need a joint replacement. So a lot of people are told that the only way they can have this problem managed is to have their joint replaced, but there's lots of other ways it can be managed. Again, just to reinforce to you, joint replacement is a wonderful procedure. It's incredibly cost effective for the right person at the right time. Unfortunately, that's not the way it's currently administered. Okay, so 1 in 4 people that have a knee replacement have a bad outcome. What does that mean? That means the pain that they came in with is no better 12 months later to the pain that they walked out with. So 1 in 4 people that have a knee replacement have a bad outcome. Many of those bad outcomes are predictable. So if you're depressed, if you're what we call morbidly obese, if you have little if any radiographic change and if you have low pain, it's much more likely that you'll be one of those 1 in 4 people that has a bad outcome. The other important statistic here that I think a lot of people often ignore is that for the average person that has osteoarthritis in a knee or a hip, they have 2.7 lower limb joints affected. So that will typically mean they'll have 2 knees and a hip or 2 hips and a knee that are affected by osteoarthritis. If you replace one, you've replaced one of those 3. It doesn't fix the other 2. A lot of people say that, sure, I'll have my knee replaced and I'll get active and I'll lose weight. Well, the studies that are out there suggest that the people that have those joints replaced don't get more active and they continue to gain weight. So it's not the way to fix the problem if we look at this as a societal burden. So, you've heard the bad story. Now I'm going to tell you about what we should be doing as far as management of this disease is concerned. And as I go through these slides, I'd like you to just reflect on your own experience. Obviously, very happy to take questions as we go along during the presentation, but I think make it so it's personal, make it so it's relevant to you. Okay, a busy slide and much of the text you probably can't see, but this comes from the College of General Practitioners guidelines that we brought out in Australia last year. And basically suggests we should start with a holistic assessment of people with osteoarthritis, a clinical diagnosis. So clinical diagnosis is based on the way you present, so symptoms, what you're complaining of, and signs. We don't need an X-ray or an MRI to diagnose this disease, and our precision in making that diagnosis is fantastic without any imaging being done. And then ideally, we should develop a tailored management plan according to modifiable characteristics of the person that's sitting there in front of us. And I'll go through what those are in a second. It's probably a little bit hard to see, but up to there in this slide, it's green. From there to there, it's yellow. And from there to there, it's red. So green is what we should be doing more of. So education, weight loss, exercise, physical activity, review of medications, mood, sleep management, topical agents, walking aids, and assistive devices. So those green things is what we should be emphasizing in the management of a person that has osteoarthritis. And as a healthcare system providing care for people that have osteoarthritis. There should be appropriate use of analgesia and joint replacement surgery. And these things in red are what we should be doing less of. And I always upset a lot of people because I include glucosamine there, but glucosamine, if you're a strong, passionate believer and you're on glucosamine and it's helping you, please continue to take it. But the best current evidence from scientific studies suggests that it's equivalent to a sugar pill in most people. As mentioned to you, opioids have no role here. Similarly, viscosupplementation, so there's the injections, repeat injections of steroids and arthroscopy have no role in the management of osteoarthritis. Where should we start? Well, we should start with education. For a person who wants to exercise, this is generally what we would advocate for. So a combination of strengthening exercise and aerobic physical activity. The strengthening exercise should be tailored and targeted towards the joint that's primarily affected to improve the strength of the muscles around there. Ideally given to you by a physiotherapist or someone trained in that nature to provide exercise. And applied, so you learn how to do that technique and you continue to do that 3 to 4 days per week as part of your regular exercise program. From the viewpoint of regular physical activity, there's lots of different options here, whether it be Tai Chi, yoga, hydrotherapy, riding a bike, whatever works for you really. And ideally what we're trying to aim for is to get a person up to do about 150 minutes per week. So if you're doing 20 minutes per week at the moment, don't jump from 20 to 150 next week. Build that up gradually over time and ideally do so under the guidance of a healthcare professional like a physiotherapist or an exercise physiologist. But again, just to focus on the fact that generally we're advocating for lower impact forms of physical activity conditioning, ideally something that you're going to continue to enjoy, because it's very hard for me to come out here and say to you, well, I think you should do yoga. And you look at me with that strange look on your face and says, David, I'm never going to do that. Okay. All right. So again, a busy slide, but hopefully something that conveys an important message. So you're at the center of this picture. Ideally, the way healthcare professionals would interact with you is they'd identify what is modifiable within that inner circle. So whether that be muscle weakness, obesity, overweight, sedentariness, knee alignment, and tailor your treatment according to the different types of modifiable factors that you have there. Obviously for overweight and obesity, diet and exercise. A person is weak, muscle strengthening. So all of those things ideally should be tailored towards specific modifiable factors when you present. And that's ideally what your mainstay of therapy should be. So obviously if you're not overweight or obese, losing weight is likely inappropriate for you. If you're strong, it may be that there are muscle imbalances there that could be corrected, but it may be that you don't need to either, and that there are other things that we should be focused on. But usually we'll find 2 to 3 modifiable things in most people that can be fixed. All right, so we spoke a bit about exercise. The next main intervention that is strongly recommended in most guidelines is that of weight loss. So for a person who's overweight or obese, it's something that makes a big difference to their symptoms. So this is a study that was done by my colleague Steve Messier that we published back in 2013, where we randomized 450 overweight and obese people with symptomatic osteoarthritis of the knee to 3 different interventions: exercise alone, diet alone, or a combination of diet and exercise. To summarize, the group in the diet and exercise arm lost 10% of their body weight over the course of 18 months through a combination of a low-calorie diet and exercise. With that 10% weight reduction, their symptoms improved 50%. So just to put this into context, that is the diet alone arm, that's the exercise alone arm, that's the diet and exercise arm. So that's a 50% improvement in symptoms. 40% of people got to a point where they had essentially a remission, little or no pain, related to their osteoarthritis of the knee. So again, just to reinforce to you, overweight or obese, 10% reduction in weight, 50% improvement in pain. Now, if I prescribe an anti-inflammatory to you, the average improvement that I'm going to get from an anti-inflammatory is in the order of 20 to 25%. So I can get a much bigger improvement if I can get a person to stick to a program like this. And you're going to say to me, well, you know, that's a trial, David. That never happens in the real world. So we have similar data from Australian community samples that show that when we get them to lose weight of a similar nature and similar volume, they get similar improvements in their symptoms. So it can be done in the general community. I get it's not easy losing weight. It's not easy sticking to a diet long term, but it does make a big difference to symptoms if you're able to follow that plan. Another resource that I would advocate looking at is a thing called My Joint Pain. So we set this up a few years ago with the support of a private health insurance company in Australia and Arthritis Australia. And it's called myjointpain.org.au. So for anybody who wants to write something down, just write that down. And it provides layperson information about what the different interventions are. It'll allow you to develop what's called a tailored individual management plan. And it provides videos about the different interventions. and resources to allow you to track the outcomes that you might be experiencing from that. It's freely accessible, so I'm not here asking for any money. You can go along there, have a look at it, and hopefully it provides you balanced, meaningful information about the management of osteoarthritis. Okay, another question that I commonly get asked at events like this is, okay, David, so you poo-pooed glucosamine. That really upset me. Do you have an alternative? I'm not here to tell you what the alternative might be, but I'm just going to give you a little bit of information and allow you to interpret that the way you want. This is a meta-analysis that we did, that we published relatively recently in the British Journal of Sports Medicine. It's a complicated slide, so I'm just going to walk you through it. But anything to the right-hand side of that line suggests that the trials favor placebo or a sugar pill. Anything to the left-hand side of that slide, that line rather, favors a supplement. The dotted line is what we would consider minimum clinically important difference. So that's the difference that means it makes a difference to you. So anything to the left-hand side of that dotted line means it's having a therapeutic effect over and above what we would expect from a placebo pill. You can see here that there are lots of glucosamine trials, 10 in total, but it does not provide a clinically meaningful effect according to this meta-analysis. So again, these are average data. Individuals might be different. So again, if you're on glucosamine and it's working brilliantly for you, just pay no attention to what I'm saying. Okay? For those of you that are paying attention, that are not on glucosamine and haven't got this current information, I wouldn't suggest going on glucosamine, nor New Zealand's other favourite green lip mussel extract, because again, it doesn't necessarily provide any meaningful clinical impacts. There are other agents that are out there, and the ones that we're very interested in doing further investigation of are curcumin, pycnogenol, and boswellia, because there's a few trials. The effects tend to suggest they're quite large. My current challenge is that the quality of the existing trials is not fantastic. Okay, so there are issues with what we call blinding and randomization that impact upon the rigor of those trials, that impair our ability to interpret them. So there is.
What were those three things again?
I'll show you on a slide. Show you on a slide in a second.
It says their vitamin E is on the right-hand side, so that can have an effect.
No. So anything to the left-hand side of that line favors the supplement having an effect. Anything to the right-hand side of that line or on the line favors the placebo, or we can't tell it apart from a placebo. So yeah, for anybody who's on one of those and they're taking it for their osteoarthritis, if you're currently not feeling a meaningful benefit from it, I would encourage you to think about an alternative. Okay? The alternatives that I mentioned, just to reinforce to you what those alternatives were those three. Again, stressing to you that the effects look large, but the quality of the trials is such that I can't strongly advocate for them at the moment, but we are doing further research on them because they do look quite appealing in that context.
Are they related to turmeric at all?
So this one is a turmeric extract. Okay. Yeah. And so just to anticipate the question that's going to come in a moment, and Diane's smiling at me for no good reason though, right? If you take raw powdered turmeric or raw turmeric, you need to ingest about 2 kilos of it per day to get an effect, okay? Primarily because your gut doesn't absorb it. So for anybody who's on raw turmeric who hasn't seen a change in the color of their poo, you haven't seen the benefit of it, okay? So curcumin is usually packaged with piperine or another product to allow your gut to absorb it. So the two products that we're interested in testing at the moment is a thing called theracumin and flexophytol, which is another activated form of curcumin. So yeah, if you want to go away and take powdered turmeric, do so to your heart's content, but it's unlikely to have a meaningful impact on your joints unless you take about 2 kilos a day.
Well, how can you get benefits by turmeric if it's turmeric's good then?
So this is the active extract. This is the curcumin, and it's formulated, encapsulated, usually with piperine or pepper, to allow your gut to absorb it.
So if I go to the chemist, what do I ask for?
So the two products that I just mentioned, one is Theracumin,
Oh, so you
and the other one is
right.
Flexophytol.
Oh, okay.
Yeah. But there are other ways that curcumin is sold as well. I'm not here, I don't make money from any of these guys, so I'm not making money from anybody, just so you know, but those are the ones that appear to have an effect.
Yeah, because I appreciate your help, because when you go to the chemist, they just display it all, and it's just very hard working which one to get.
So I talk a lot with various pharmacists, and you've got to understand that there is obviously a health benefit that they're trying to provide, but there's also a commercial benefit that they're trying to redeem from a business perspective. And so a lot of the products that are currently their main sellers in pharmacies, and how many pharmacists in the room right at the minute? None? Good. Well, I'll have some tonight, I'm sure. But their main sellers are often the glucosamine, the chondroitin, the Panadol, which I'm obviously poo-pooing and hopefully suggesting to you a lot of other alternatives. Okay, so walk away from today with the message that ideally there are lots of other things that you can do about managing your disease, educating yourself, exercising, losing weight, and various other interventions tailored towards you with the help of a very proactive group of healthcare professionals. That will typically, on average, improve your pain. The vast majority of people never need a surgical intervention if managed appropriately. And that's the way we're traditionally managing that now in Australia. So most of the patients that come through our programs never need surgery. So I want to open it up for questions, but just in closing, osteoarthritis is a very prevalent problem and the leading cause of disability in our community, along with some other musculoskeletal diseases. Obesity and aging are increasing, so we're going to see an increasing number of people that have this problem. And there's lots of different ways that we can manage this as a society, but I guess what I just try to reinforce to you is that appropriate non-operative management that I've really tried to hopefully emphasize to you today. I want to close in thanking my supporters, National Health and Medical Research Council, Arthritis Australia, my research team, the Institute of Bone Joint Research Group and my clinical group, my own research group. And leave you in closing with an image from Waiheke yesterday. It was a beautiful part of the world for anybody who's not been there, but if you ever get a chance, thank you. And I'd also, again, like to acknowledge Arthritis New Zealand's support for the opportunity to come here today and for your attention, but open it up for your questions. Thank you very much.